Without any further notice, thank you all for joining us today. We look forward to an engaging and enlightening webinar. Dr. Kanch, the floor is yours.
Thank you, Zainab. Can you stop sharing so I can share my screen? Okay. Can you see my screen? Can you see my screen, Zainab?
Yes, yes.
Good morning, everyone. Thank you, Zainab, and thank you for the Global Health Institute at AUB for inviting me to be part of this webinar. As you can see, my face is black because in Lebanon, we continue to have electricity cuts at 10, 12, 2 p.m., etc. So very shortly, you will see my face again when the electricity is back on. So I'll be speaking on antimicrobial resistance and stewardship in the displaced population in the Middle East. These are my disclosures. None are related to this topic of today's presentation. So let me start by giving you a bit of an overview on antimicrobial resistance in the Middle East. What do we know so far? And if we look at this data, this is a review paper that was published in 2018 in response to an invitation we received from Lancet ID to put together data on antimicrobial resistance in the Arab countries of the Middle East. And really, while trying to put the data together, we were faced by many challenges. A lot of the countries did not have standardized AMR surveillance. The published studies had a lot of variability in the techniques in interpreting susceptibility, in the origin of the specimen, and the choice of the specimens, whether they're non-invasive or pooled data. Nevertheless, we were able to put together color-coded maps that look at the critical priority pathogens classified by the World Health Organization. And so whether you look at the gram-negative bacteria, such as Enterobacterialis, Pseudomonas, Acinetobacter, or the gram-positive one, the common ones that we deal with, Staph aureus and Strep pneumo, we have high rates of resistance in many of the Arab countries. The darker the color, the higher the rate of resistance. But also one noticeable thing on these maps is that even neighboring countries had different rates of resistance. And that's why it's very important to know your own rates of resistance in the individual countries. And when we talk about antimicrobial resistance, obviously consumption of antibiotics play a major role. And from this data from 2018, as you see, many of the Arab countries, whether they belong to high income, upper middle, or low income countries, we are among the countries that consume a lot of antibiotics. And there are many challenges that exacerbate AMR in some of the Arab countries. As you know, outpatient antibiotic prescription is not controlled in many of the countries. Patients self-medicate with antibiotics. Even in countries that have antimicrobial stewardship program, this is limited to inpatient setting and not extended to outpatient setting. And also, even in countries that have relatively good control of their antimicrobial resistance, they get transfer from other countries of patients who have high rates of resistance. This is from the WMRU region, published 2 years ago, looking at the national antimicrobial stewardship core capacities in 20 countries in the WHO EMRU region. And as you see, really, antimicrobial stewardship is not adequately implemented in many of the countries. For example, if I look at dedicated funding for AMR and AMS, only 1 out of the 20 countries said yes. Awareness, training, and education. None of the countries had in-service training for AMS and antimicrobial drug prescribing. So these are really alarming low rates of AMS implementation that should really push us to work very hard to improve these. And when we talk about AMR in 2024, we cannot but bring the concept of One Health, because as you know, we are exposed to antimicrobial resistant pathogens, not just in the hospitals. We are exposed from animals, from the food we eat. And so when we want to tackle AMR, we need to think of the One Health approach. And in the Middle East, in the Arab countries of the Middle East, unfortunately, very few countries have started implementing the One Health approach. There is a model proposed by Qatar now that seems to be working, and hopefully with time, we'll see more One Health approach implemented in many countries in the Middle East. Now, let me start talking about the wars and the displaced populations in the Arab world. This is the topic of today. And how does this interact to fuel the antimicrobial resistance problem? As you know, our region has endured colonial, anti-colonial civil wars and long-term conflicts. Actually, it is estimated that since 2001, it has been one of the regions most affected by wars. And as you expect during wars and conflict, we have high number of wounded people. The nature of injuries are really devastating, a lot of denuded tissues. In the conflict setting, there is loss of diagnostics, healthcare personnel, and loss of infrastructure. Add to that, there is displacement of refugees, the collapse of the sanitation control, and even in countries that had field hospitals during wars and conflict, these were under-resourced. And all this constitute what was labeled as AMR in the Middle East as a perfect storm. This is a paper published a few years ago where they tried to compare the antimicrobial resistance among the class WHO pathogens in conflict and non-conflict affected settings in the Middle East. And if you see here on the map, the fragile and conflict affected areas are in blue, the non-affected are in green. Now, to note that only 6 out of the 18 countries were adhering to the class surveillance of antimicrobial resistance. And of these 6, only Lebanon was considered or is considered a fragile context. Nevertheless, if we look at the overall data from the systematic review, we see that carbapenem resistance in Acinetobacter is sky high, 74% a median. Extended spectrum beta-lactamase producers, also very high rates, but even carbapenem resistance among Enterobacterialis that are very common bacterial pathogens in not only hospital, but also community-acquired settings. As you see, the rates are high, 8 and 15.4% respectively, but also for the gram-positive pathogens, Staph aureus and penicillin, high rates of resistance. They found in the systematic review that there were similar trends in conflict and non-conflict affected countries. However, there are many reasons for those findings. I think, as you can imagine, in conflict settings, we have less precise data. Accessibility to antibiotics is much less, and maybe this can be a factor minimizing the selective pressure on bacteria, but also there are publication biases, and in general, in conflict areas, among healthcare workers, among health authorities, there is less awareness about the importance of AMR. Now, if we want to look at displaced populations in the Middle East, as you know, 14 countries have more than a third of the world's refugees. Here, I'm going to share some statistics from 2022, and they were 15.7 million internally displaced people in the Middle East, North Africa region, which constitutes 26% of the global number of the internally displaced people. And it's really the second highest concentration of IDPs following sub-Saharan Africa. Now, up until 2022, most displacement had been triggered by armed conflict in Iraq, Libya, Syria, Yemen, and of course, Palestine. And if we look at refugee camps, I put here examples from Jordan, Lebanon, Gaza, and Yemen. And as you see, there are common factors among these refugee camps. There's overcrowding, these are inadequate shelters, there's insufficient nutrient intake, poor vaccination coverage, and very importantly, poor water sanitation. All these will fuel infectious diseases in general, including the development and spread of antimicrobial resistant pathogens. This is a systematic review and meta-analysis from Europe, from John Friedland's group, looking at what are the rates of resistance among patients coming to Europe as refugees. And they looked at colonization and infection, and the overall rates of resistance was really high, 25.4% of the cultured organisms were classified as AMR. And if we look at the gram-negative, drug-resistant gram-negative pathogens, 27% of all migrants who had pathogens isolated, they were MDR gram-negative. And on the chart here, you see that a lot of these patients came from some of the Arab countries, including Syria, and other came from other countries in the Middle East that are listed here. Let me talk a little bit about Syria. This is a country, as you know, the war in Syria started in 2011, so and it continues now. And one of the things that's really disturbing is that there is very little published data on AMR in Syria. So you'll find like small reports such as this one, very low number of isolates tested, but those that are tested really show very alarming high rates of resistance. Look at Acinetobacter baumannii, for example, multi-drug resistance, 100% resistance among many of the broad-spectrum antibiotics. And since there have been some reports published from Syria, one study showed that multi-drug resistance was detected in more than 70% of the patients who developed infection. This is on the right, a paper that we put together with the group of Aula Abara, who's at the Imperial College of London. She's of Syrian origin and very interested in AMR in Syria. And the numbers that and the rates that we found from connecting with some of the microbiology labs in Syria were alarming. 20% CRE in E. coli, 64% tigecycline resistance in Acinetobacter, but also colistin, a drug that's considered a last resort drug. They were 8 and 9% resistance to E. coli and Klebsiella. There are many drivers of AMR in Syria. Some of them existed pre-conflict. You know, not all of the drivers came after the conflict. Even pre-conflict, availability of antibiotic without prescriptions, lack of stewardship, poor infection control and prevention practices. They did not have any nosocomial surveillance, and very few microbiologists and trained infectious diseases specialists. Obviously, all this, the challenges were exacerbated during the conflict, destroyed health infrastructure, total fragmentation of the healthcare system, and exodus of many healthcare workers, overcrowding, displacement, and lack of availability of antibiotics. And the consequences is that we have no surveillance in Syria now, very few microbiological labs that are working, there's no quality control, and a lot of nosocomial transmissions in the hospitals. And at the end, look at the smuggling of fake antibiotic. One of the major drivers of antimicrobial resistance is when you use qualified antibiotics for treatment. And the war in Syria generated a lot of refugees. Some of them were internally displaced within Syria, but a lot of the refugees left Syria to neighboring countries, Turkey, Jordan, Iraq, got their share. But as you see here, Lebanon, which is really a very small country that is already struggling with many challenges itself, it has the second most a high number of refugees from Syria. So Lebanon is estimated to have the highest per capita concentration of refugees in the world, estimated as 173 refugees per 1,000 inhabitants. So currently a quarter of the population of Lebanon is made of refugees. Obviously, this is very well known for the Lebanese audience, but for the non-Lebanese audience, this number can be really shocking. Now, there is a lot of data published on AMR in Lebanon. As you know, many hospitals in Lebanon operate as per the highest standards, and we have active stewardship programs, we have very active infection control programs, and we have very good surveillance data at the level of the hospitals. This is an example of our data from the American University of Beirut Medical Center, data collected by our very active infection control officers and program. And as you see, a lot of fluctuations in the antimicrobial resistance among the WHO critical and high priority pathogens. But just to say that in Lebanon, the first carbapenem resistant Enterobacterales cases that we saw in patients were from Iraqi patients. We don't have a national surveillance data that differentiate between refugees data and Lebanese data on the topic of AMR. We do have such data for hepatitis, for measles, for other vaccine preventable diseases, but not for AMR. But this here is a study that looked at Syrian refugees admitted with war-related wounds to Lebanese hospitals, and they were much more likely to harbor carbapenem-resistant strain than Lebanese population, so 74% versus 47%. And there are many challenges for refugees in Lebanon, obviously with the economic collapse that happened since 2019, with the devaluation of the Lebanese pound for over 90%, a large number of the Lebanese residents currently live in poverty. And so you can imagine if the Lebanese residents live in poverty, the refugees are in even worse situations, and a large number of the current inhabitants of Lebanon have barriers in accessing healthcare due to cost. And typically refugees are at high risk to have complications from infections. So from the COVID data, for example, we did see a higher mortality among the Syrian refugees who had COVID compared to the Lebanese populations. And so with the inadequate clean waters, all this really create a very high concern for rising AMR in Lebanon. What about AMR in Iraq? This is another country that has been affected by a series of war. I just like to say that prior to the 1970s, Iraq had one of the best developed healthcare systems in the region. Obviously, all this has been shattered now. One issue that has been discussed a lot is the role of wars and conflict in selecting for multi-drug resistant pathogens such as Acinetobacter, which, as you recall, was labeled as Iraqi bacter at the beginning of the Iraqi war. I will not talk about this heavy metal toxicity in armed conflict because I trust Dr. Abu Fayyad will touch base on this important topic. In Yemen, another country that is really affected by war, we have a lot of resistance. However, this is just based on talking to colleagues, but we don't have any published data. There is just this survey for physicians and pharmacists that was published recently that really highlights how 96% perceive that they have high AMR rate, but the majority also are selling antibiotic without prescription, 67%. So a lot needs to be done in Yemen. And I think if we start collecting surveillance data, we're going to be shocked at the high level of resistance. And now let me move to Gaza. Gaza had a very high number of its population living in poverty before the October 2023, as you know, in 2022, unemployment reached more than 45%. And of the data prior to the current Gaza war, the very little data that is published shows very alarming rates of resistance. So I pick on Klebsiella because it's a common pathogen in community and hospital-acquired infections. 22% were resistant to carbapenems in 2020, 25% were resistant to carbapenem in 2022. And data from Médecins Sans Frontières really suggests that there is a high rate of bacterial contamination in hospital waters with high resistance to carbapenem and cephalosporins. And you can imagine how this will affect the rates of AMR in hospital setting. Now, in the Gaza war, there are many drivers of AMR. Since October 2023, more than 3/4 of Gaza's populations are internally displaced. As you know, now people are crammed in Rafah under very, very poor conditions. And the hospitals, a lot of them, the majority, are completely destroyed. So when we talk about drivers of AMR in the setting of the ongoing Gaza war, really you can list all these factors that are very concerning, that the AMR is going to go up the roof, no infection control, no infrastructure, surgeries are being done without gloves, no antibiotics, and so on and so forth. Christelle Musalli in this editorial, Christelle works in MSF. In the Lancet, she said, what is happening is beyond words, and it almost feels futile and unethical to mention antibiotic resistance. But even after the war stops, we're going to be seeing very high rates of resistance in Gaza. It's really going to be a major, major challenge. And in this report by the Geneva Water Hub, it's a very lengthy report, and it talks about how water and sewage, which should never mix, are mixing at big, big level in Gaza in all the places. And they really talk about how can you talk about a One Health approach to AMR in a setting where you have water and sewage mixing. I really highly recommend to read this report. So in the last couple of minutes, I'll just talk about proposed solutions. So what can we do? We need to intensify surveillance. We need to train the staff. We need to ensure that their learning is adequate. We need to make resources available for microbiological services. And obviously, in the process, we need to improve quality control. This is from a recent review, basically saying the same thing, that if you want to address solutions in stewardship among refugees, you need to expand studies on surveillance in displaced population. We need to include diagnostic stewardship in resource-limited area. And again, education of the healthcare practitioners, and in the process, consider addressing cultural and societal barriers, because what works in the US and Europe might not apply to our countries in the regions. The Médecins Sans Frontières have proposed some pillars of AMS in war zones, and the basic package, and they say all projects should include AMS and IPC, and if possible, do the full package with microbiological surveillance in war areas. When we talk about infection prevention and control in war settings, we really need to think about simplified but high impact intervention. And collaboration with local ministries of health is of great value. So the model of build it, teach it, check it, sell it, and live it is a model that has been working in some of the conflict areas. And again, when we talk about microbiology, diagnostic, and surveillance, we need to think more and more of point of care setting, because these are settings that do not have expertise in laboratories. So the point of care testings can have a short turnaround time, high sensitivity and specificity, reducing the time of diagnosis, easy to use tests, and so they can have a great impact in conflict setting. And in some settings, we need to think about taking advantage of artificial intelligence, where, for example, antibiogram analysis can be done by just taking a picture on the cellular phone. This is what MSF has been using in some of the countries. It's called ND-Biogo. It's an application to tackle antimicrobial resistance, and a very good thing to have when you don't have good microbiological diagnosis. And another sample of antimicrobial prescription practices, this was done in Yemen, where MSF trained the Yemeni doctors. The Yemeni doctor went back to practice in Yemen, but they keep this coaching on a daily basis to ensure that MSF practices are, that AMS practices are being implemented. And this is more of a train-the-trainer model. And then lastly, we need to think about accelerating antibiotic access. In this paper that we put together with the GARDP, a Global Antibiotic Research and Development Partnership, we talked about how we need to think outside the box. We need to think of a stewardship program that ensure that people, regardless of where they live, even in low middle income countries, they can have access to the novel drugs if they need them desperately. We can't talk about AMR without stressing on the importance of the vaccine. And last but not least, the Sigili, which is the cloud-based electronic health record that was established in collaboration with the Global Health Institute at AUB, can serve as a very good model to really track the health of the refugees, including their colonization and prior infection with antimicrobial resistant pathogens. And then finally, how can we achieve much without collaboration? In the regions, we have a lot of experts in many countries. We have a lot of wealthy countries, and we have a lot of academic centers. I think together we can reach really an impact. So I think I'm going to stop here to stay on time, and I'm going to stop sharing, and I think we'll leave the Q&A till the end. Thank you.
Thank you, Dr. Kench, for the very enlightening presentation. Yes, we will leave the Q&A till the end, and now we can give the floor to Dr. Antoine.
Good morning, everyone. Again, thank you for this opportunity to be able to present to you a bit what we do on AMR and conflict from a lab perspective. Just 1 second. Can you please allow me to share my screen?
Yes, sure. Done. You should be able to share now.
You?
Yes.
Right. So my name is Antoine Abou Fayad. I'm an assistant professor at the American University of Beirut at the Faculty of Medicine, Department of Experimental Pathology, Immunology, and Microbiology. And we're also part of the Center of Infectious Disease Research at the university. I'm a chemist and a microbiologist by training, and I'm going to be talking to you today about AMR and conflict from a laboratory perspective. If we look at the emergence of MDR or drug-resistant Acinetobacter baumannii, and we plot it against the timeline of wars globally, starting from the Vietnamese War is when we started observing MDR Acinetobacter baumannii. After that, in 1985, there were several wars that were going on. The Iraq-Iran war, there were several wars in Africa, there was the civil war in Lebanon. We started observing XDR, Acinetobacter baumannii, and in 2007, was the first time pan-drug resistant Acinetobacter baumannii was observed. And back then there was a war in Afghanistan, the Iraq war, there was the Lebanon and Israel war in 2006, and there was also a war in Gaza. So if we try to understand a bit more this emergence of Acinetobacter baumannii over that timeline, there must be a relationship somewhere between war and emergence of Acinetobacter baumannii multi-drug resistant. So if we look at the first report of an NDM1 producing Acinetobacter baumannii in Lebanon, that was from a civilian who was injured in the Syrian war. And even if we go back further in time, NDM stands for New Delhi beta metallolactamase. And this was isolated from an Iraqi patient who was injured during the Iraqi war and went to India to seek medical care. And this is where the first NDM was actually observed and recorded. So basically, I'm not going to talk a lot more about the drivers, all of the drivers regarding AMR and conflict. Dr. Kench already gave a very good image about that. But what we are going to focus from a lab perspective is what we observe within clinical samples and what could be the drivers in addition to the displaced populations, in addition to the lack of microbiologists during conflict, and the lack of policy as well. So as Dr. Kenj mentioned, there is a lot of scarce surveillance in the region, right? Especially in the Eastern Mediterranean region. Not all countries are reporting, and not all countries have the capacity to report and the ability to actually produce data that could be useful in order to monitor the trend and the emergence of antimicrobial resistance. And data sharing as well in our region is a bottleneck. Countries don't like to share data. They don't like to report on the emergence or re-emergence of certain infections, be it cholera, be it other bacterial infections. So we, in our lab, we started working with several partners across the globe to try and understand this phenomenon. And I will start with Gaza. We worked with Reem Shumar, who actually did a fantastic job pre-October 2023. And we looked at the link between WASH and AMR in one of the hospitals in Gaza. And actually, the results were a bit shocking. When we looked at water and wastewater bacteria that live in the water and wastewater of the hospital, the percent resistance of bacteria to Astreonum were 100%. We have had 50% resistant to ceftazidime avibactam and 50% resistant to meropenem as well. And this tells you already that the wastewater is not being treated properly. The water that is used in the hospital to wash hands prior to surgery is also not treated properly. So these drivers also help in spreading AMR and drug-resistant bacteria across. We also looked at Acinetobacter from Libya. And if you look at the bottom side of the slide, so here, cluster 1 and cluster 2, this is a standard outbreak of Acinetobacter in hospitals that you would see usually in Europe or in the US. And what does this mean? You have one cluster coming from one hospital, and you will have another cluster coming from another hospital. But when we looked at hospitals in Libya, and our collaborators there sent us a decent collection of Acinetobacter baumannii isolates, specifically from war-wounded patients, and looking at burn injuries, to be very specific, you can see that you have 3 hospitals that are geographically far away from each other. But you can see that there is no clustering of the isolates. So there is a scattered clonality. It's not a monoclonal outbreak like you see here in the bottom. And this is something that makes things a lot more difficult to deal with for infection control people and for infectious diseases specialists, because your isolates don't have the same profile, and the treatment options would not be the same. We've worked also with quite a lot of people from Syria over a period of 2 years, where we've collected with them around 2,000 samples of gram-negative bacteria. and the percent of misidentified bacteria were very high. 60% misidentified microorganisms is actually quite bad. So we've actually been working on training those laboratory personnel and laboratory technicians to actually be able to do better identification of the bacteria. And we're hoping that in the near future we would go back and revisit another sample collection, and hopefully the balance will tip to the other side. One of the publications as well that we've worked on was Klebsiella pneumoniae, which was isolated from a soldier who was injured in Arsail. And one of the very interesting things that we've observed was an isolate which had 36 AMR determinants in one strain. So 36 genes or determinants that are responsible for antimicrobial resistance in one strain, which was in that soldier. And this actually was a bit of a shock to quite a lot of the microbiologists globally due to the high number of genes. Luckily, that bacterium did not spread, and infection control did a brilliant job at limiting the spread of that bacterium. In addition to what we've discussed previously, the polyclonality versus monoclonality, the link between WASH and AMR, we've also, and this is with the help of Dr. Ghassan Abu Sitta, we studied the misuse and abuse of antibiotics, specifically in the Eastern Mediterranean region. Dr. Kench touched base and explained the lack of prescription policies. There is also the agriculture sector, the poultry sector, the poultry farms and the fish farms. These also use a lot of antibiotics irrationally and without control. And one of the very interesting facts that we learned was antibiotics that are near expiry usually are dumped at a conflict site to be used empirically within a few months without any rational use. This information we got from Dr. Abu Sitta and from Dr. Richard Sullivan. Adding to the misuse and abuse and forced to use antibiotics, back then came COVID and the irrational use of antibiotics, especially in our region, with the use of azithromycin, so that's known as Zitromax, that thought to cure a viral infection. And we've started observing now a trend of rise of resistance to azithromycin, which is something that we're gonna have to pay for dearly in the very near future as well. Another driver to AMR and conflict is substandard antibiotics that are locally produced. And this is a very sensitive topic that we've been working on for the last while, and we are going to see the first publication coming out very soon. We've looked at antibiotics that are produced in Syria, in Jordan, in Turkey, antibiotics that were produced in Lebanon. Now we haven't seen any lately, and antibiotics that are imported. And if you look at the efficacy of the antibiotics, the ones that are produced in our region actually don't match the killing efficacy of what is imported from the Western countries or from developed countries. And this is quite alarming. When you're talking about a dosage discrepancy, instead of 500 milligrams, you have a 200 milligrams at best. This is one of the best ways to raise drug-resistant bacteria. Another driver for AMR that I'm gonna be we focus on a lot on in our lab, and I'm gonna be talking about a good bit, is how can superbugs emerge from destruction, from bullets, from shells. So if you look at the published UNEP report for Lebanon post-2006 war, and you look at the studies that were done in Iraq, there was a big rise in heavy metals in the environment. And if you can see here, for example, you're talking about almost a gram of iron, of lead, a decent amount of nickel. All of these heavy metals, they can affect drug-resistant bacteria. How could that be possible? So pre-antibiotic era, right? So pre the discovery of penicillin and sulfonamides, we've had humans used to use copper and other metals as an infection treatment, as an antibiotic. And we know that heavy metals do have a method to kill bacteria. So if you can kill bacteria with something, that means bacteria can learn and adapt to become resistant to it. So we started looking at how come bacteria in the environment can become resistant to heavy metals, and in the same way, they would become resistant to antibiotics. You would think that the heavy metals and antibiotics are not the same. So how could it be possible? Take also into consideration that all the bacteria that infects humans and are pathogenic, they are also found in the environment. Acinetobacter, Pseudomonas aeruginosa, E. coli, Klebsiella, all these bugs, they live in the soil, they live in the water, they're everywhere around us. So when we started looking at certain mechanisms, we could basically classify them into three different methods. There is something we can call cross-resistance. It's when one gene is actually responsible for the resistance towards both antibiotics and heavy metals. And this could be an efflux pump, which is something that we started observing in Acinetobacter baumannii and in Pseudomonas aeruginosa, specifically against lead and aminoglycosides. There is something called co-resistance. So when two genes of antibiotic resistance and heavy metal resistance can exist on one plasmid, right? And plasmids, just for further explanation, are very small circular DNA that bacteria can pass to each other. So bacteria can teach each other how to become resistant to antibiotics and heavy metals by using these plasmids and communicating with each other, passing them to each other. And there is something we call co-regulation. Co-regulation is when we have one regulator that can control two genes. One is for antibiotics and one is for heavy metals. This can also be efflux pumps. It can also be porins, right? And porins, so efflux pumps, as the name suggests, is what pumps from inside of the bacteria to the outside. While porins is the gate that allows minerals, antibiotics, proteins, anything that the bacteria wants to go from the outside towards the inside of the cell. And co-regulation can exist in both, either in porins or in efflux pumps. So what we did, we set up a way where we started incubating Acinetobacter baumannii, a control strain, which is very well known, very well understood, in the presence of certain heavy metals that do come out of destruction, come out of shells, come out of bullets. And we even incubated the bacterium in the presence of shells and bullets and shrapnels. And we started observing very strange behavior of the bacterium, very strong resistance and very strong resilience, in addition to biofilm formation. So there is something within that environment that activates Acinetobacter baumannii to form biofilms, to become dormant, but while becoming dormant, to learn how to become resistant to lead, to zinc, to nickel, to copper, to arsenic, to manganese, to iron. And when these are activated, the resistance trends that we are observing are very scary. I haven't shown you any results because this is still ongoing, and we are still in the process of analyzing a bit further with our colleagues in over in Cologne and in Sherbrooke in Canada to actually understand it a bit more and try to figure out how really this is all working and how these are getting activated. But hopefully in the very near future, I'm sure GHI will be communicating the papers when they are out. In conclusion, what we observe in the lab as main drivers for antimicrobial resistance is the lack of surveillance and lack of workforce, as demonstrated both by Dr. Kenj and by myself. Very scarce sequencing to understand at the molecular level what's going on, which is very crucial. And we know for a fact now that the whole region is well equipped to actually do sequencing for surveillance. We know that all countries post-COVID have been supplied by WHO with sequencers, and the personnel have been trained. There is a lot of hampered detection and misidentification of microorganisms. There is a lot of substandard antibiotics that are being misused. And even if they were tried to use properly, these substandard antibiotics are causing a lot of harm. And the heavy metal contamination is one of the very, very main drivers when it comes to antimicrobial resistance. And thank you. I'm happy to take any questions.
Thank you, Dr. Antoine. Thank you so much for this very enlightening presentation. I think now we will open the floor for Q&A. I would like to kindly ask our attendees to drop their questions in the chat box, and we will be discussing them.
Zainab, if I may start while you're getting your questions from the attendees. I thank you, Tony. I really enjoyed your presentation. So if I can start by asking Dr. Abu Fayyad, so if we're going to think about surveillance in countries that are affected by conflict, and, you know, as I mentioned in my presentation, in the Arab countries, we really have very, very little data, and there is almost no surveillance that's happening. So in terms of practical steps, let's say we get a good amount of money, funding to do surveillance in some of these countries. What do you think would be a model that can inform us in a very cost-effective way in terms of laboratory capabilities, etc.? And I'm talking more about like the practical things.
Mm-hmm. Thank you, Dr. Kenj. This is actually a very, very good question and a very hot topic at the moment in the region. One of the bottlenecks that we have is that bacteriology, specifically bacteriology, in the Eastern Mediterranean region is very weak. The problem is bacteriologists are not very common anymore. And whenever you have a very good trained bacteriologist in our region, they are actually moving away. We actually go around with WHO within the region, and we train those people on bacteriology. After a long training and after a year of follow-up, you would discover that this person has left, moved on. They moved to Europe, they moved to the US, they moved to another country to actually have a better life and have a better job. So you go back to square zero. This is one of the problems that we are facing. Another problem we are facing is that a lot of the countries actually do have surveillance programs, and they actually do quite a very good job at it. The only problem is that they don't share the data at all. And this is due to political reasons. Now, once we get the politicians to understand how important surveillance data to be shared and to be understood by the global community, we can overcome the second bottleneck. A very good model would be actually starting from the basic bacteriology, where we would teach them the correct quick identification method, maybe using MALDI-TOF, for example, because it's not laborious, it's very smart, and it takes 2 minutes to identify a bacterium. After that, they can do antimicrobial susceptibility profiling. There are now automated systems that can do that to minimize human error and to decrease the training amount that is needed to actually train personnel to do it. This could help us gather more data, understand a bit more what's going on. And one of the things that also is being developed in the region, there is a lot of training hubs. You know quite well that the Department of Experimental Pathology, Immunology, and Microbiology is a WHO collaborating center. And we are a training hub as well. So what we usually do is we have 4 or 5 trainings every year where we get people from across the region or even across the globe to give them these trainings, whether it be at tier 1, which is basic bacteriology, tier 2 is a PCR level, and tier 3 is the most advanced, which is the next generation sequencing and whole genome sequencing. So a good model would be splitting the countries into tier 1, tier 2, tier 3, without telling the countries, obviously, so nobody feels offended. And then you would actually give them the basics training and try to minimize human error as much as possible by introducing the new technologies which are available, as I mentioned, of MALDI-TOF for identification and a VITEC for the susceptibility that could actually give us the good results.
Zainab, you're muted, I think.
No, I'm here. I don't have questions so far from the chat box. Maybe we'll give it 2 more minutes before we close.
Yeah, I think just one to answer back also on the same issue. I mean, even in countries that have good surveillance systems, so if I take Jordan, for example, which is part of GLASS, but also part of the smart surveillance system for gram-negative resistance, they don't seem to have adequate differentiation between surveillance in displaced populations versus in the you know, non-displaced, the Jordanian inhabitants. So I think we really need to think about try to be innovative in understanding more the AMR in the displaced populations, because these people will travel from one place to the other, and you know, they can transfer these multi-drug resistant pathogens wherever they go. As we know, bacteria have no boundaries. So like, you know, you wherever you go, the hosting countries, this is a big deal now in Europe also.
Yes.
A lot is being done to control the AMR in Ukrainian refugees. You know, here, obviously, today we focused on the Middle East, but in Ukraine, there's a lot of efforts by CDC and other organizations to try to understand the epidemiology of AMR in the Ukrainian refugees, because they're afraid that their MDRO will spread to the hosting European countries as well.
Actually,
4 questions in the Q&A.
yes, exactly. There are 4 questions in Q&A. So I'll start with the first. Can you enlist all the known antimicrobial resistant mechanism? One is for efflux mechanism.
So technically for antimicrobial resistance, you have 4 major mechanisms of resistance. Efflux pump is one of them. Porins is the other. So when instead of overexpressing efflux pumps, the bacteria will underexpress porins to limit the number of gates, as I mentioned, or doors open on the membrane to allow things in. Another major resistance mechanism is when bacteria produce enzymes to actually deactivate antibiotics. And the 4th is when bacteria can change the binding site where antibiotics would sit to actually cause their effect. And basically, some of them, they can be communicated from one bacterium to another. So efflux pump can be communicated. The enzymes that deactivate antibiotics can be communicated using plasmids, as we mentioned previously. Those are the 4 major mechanisms.
Okay, thank you, Dr. Abu Fayyad. Another question is, someone says, both of you mentioned a number of ways to tackle AMR, including proper surveillance and training. However, these are far-fetched in reality and will not solve the issue immediately. Knowing as a fact that this is an extremely worrying topic and discovering new antibiotics is not a straightforward task, what are some suggestions to attenuate resistance, if not eradicating it?
Yeah, I think I can tackle this one. So, you know, as I ran through it rapidly, but I think the important message here is we should not say we can't do much because we have too many challenges in the region. So I think we should start somewhere. I think if we teach people on proper infection control practices, we will be achieving something in controlling AMR. If we train the people about the proper use of antibiotics, shortening the duration of treatment rather than giving 14 days to everyone, ensuring that our pharmacists are checking the quality of the generic products that they introduce in the hospital, this will be very impactful. But also train the trainer model has been working very much in, Dr. Abu Fayyad spoke about their lab and training the bacteriologists, but also we can do the same for stewardship. Train the trainer model for stewardship. I think the MSF trial that they did in Yemen proved to be very effective. So I think we need to start somewhere rather than saying, we have too many challenges, we can't do much. I think starting somewhere with IPC, stewardship, quality of antibiotics, limiting the duration of treatment, etc., will have an impact.
Okay, thank you, Dr. Kenj. Another question says, AMR at national level needs to be developed and supported. Major private hospitals can play a role. Is that possible? Probably the person is asking about whether major private hospitals can play a role in that.
Yeah, I can tackle this one as well. I think definitely. I think, in various countries, if I take the example of Lebanon, the Ministry of Health is developing a national action plan, which is what WHO has called for. And by now, the majority of the countries globally have really started developing national action plans. And I think it happens that in the private hospitals, for example, in Lebanon, you have a lot of expertise in stewardship and infection control. So the short answer to this would be yes. I think ministries need to rely on private hospitals that have expertise and use that expertise to adapt their national action plan that can be effective.
Okay, thank you. So the following question, the person says, hi, thanks for the great presentation. No data is for Pakistan. Probably the person is inquiring whether we have any data on AMR about Pakistan.
I think there is a lot of data on Pakistan. The aim of this presentation was to talk about the Middle East and Arab countries, but there is a lot of published data on Pakistan. I think if we look at AMR in India and Pakistan, these are two countries where AMR is really a huge problem. I think some of the carbapenem-resistant Enterobacterialis, initially the NDM, the New Delhi metallobeta-lactamases came from that region. So it is published, but with the limited time, we really were restrained to talk about the Arab countries.
We're also focusing on countries in conflict, and Pakistan is at the moment, and hopefully it stays out of conflict.
Yes, of course. Okay, so the second question comes, thank you for the informative sessions. Do you have any experience on surveillance systems that use the One Health approach in detecting AMR in our region? Example, environmental samples?
Yeah, we do.
Yeah.
So we've been actually running a One Health approach model, quote unquote, for Lebanon. And at the moment, our study is in review. Hopefully, it will see the light of day soon, where we've actually looked at AMR. It will be the first also study from the region that tackles One Health approach as a whole, not just one arm of the One Health approach. We've actually looked at clinical samples, environmental samples, and wild animal samples, not domestic animals only, including wild animals. And the numbers are shocking. They don't make us happier. They actually show us how bad the situation is. But tackling One Health needs to either bring everybody on the same table, because the second question also tackles farms and food industry. And this is also the One Health. You either bring everybody on the same table and everybody has to see eye to eye, because the clinicians cannot do all the work by themselves, and the pharmacists cannot do all the work by themselves, and the stewardship people, I mean, I'm pretty sure Dr. Kenj will add to what I'm saying, and the lab people cannot do everything by themselves. It has to be a unified approach. It has to be under one umbrella to look at the whole thing from one unified angle.
Yeah, I mean, just very briefly to add to that. So Qatar and UAE are working very hard on this. I think we'll be seeing some data soon. But also from Lebanon, you know, Dr. Ismat from the School of Agriculture has already reported colistin resistance in E. coli from poultry. So I think we'll be seeing more and more work as a One Health approach to AMR coming up soon.
Great. I think we have also addressed the following question, which is what about the use of antibiotics in farms and food industry? We'll jump to the following. So it says attack and destroy principle can be applied to limit the extension of AMR germs. I think this is a comment more than a question. And the
Yeah.
last question says, AMR program needs multi-sectoral response, strong political support and fund. To get there, a CEA is needed for a politician to understand economic return of intervention. Do we have concrete studies on that?
So I think, you know, there is a lot of movements to popularize AMR, including involving the politicians, etc. I'm not sure if there are any published data, but as you know, the UN General Assembly in New York, that's going to happen in September, you know, the main topic of the United Nations General Assembly is AMR and what can be done. And I think this is going to generate a lot of political interest in being a part of AMR work. Already, the UK has dedicated a huge amount of money to work on this. And I think this came with the political support. I can tell you, I was part of a panel at the EPaPP, which is the presidential advisory to the United States, which advises the president on what needs to be done for AMR. And there was a huge interest of, you know, helping from FDA, from NIH, from the various political representations in the EPaPP meeting to work together to address AMR. So I think we're going to be seeing more and more examples of how we can incorporate all stakeholders in the fight against AMR.
Okay, thank you, Doctor. I think the last question we have, this question is intended to Dr. Abu Fayyad. What's your opinion on the newly synthetic drug cresomycin? Have you tested it in your lab? Do you believe synthetic drugs are recommended to tackle AMR instead of natural products?
Do I believe I'm going to answer the last question first. Do you believe synthetic drugs are recommended to tackle AMR instead of natural products? I believe any drug that can tackle AMR should be used. It doesn't matter the origin. There are people who, like me, when they do drug discovery, we go to natural products because it's a niche. There are people who actually go for synthesis. They synthesize molecules, they model molecules. Some of them work, some of them don't. But one of the reasons that pushes us to go to natural products is very simple. These natural products are made by bacteria to kill other bacteria in the environment. So all what you have to do is go there and fish it. That's all what you have to do. But remember, you need to get in vivo activity and no cytotoxicity. And the current rules that are set to actually get an antibiotic from bench to bedside are horrendous, to say the least. They are really difficult. And if you would look at all the antibiotics that we are using at the moment, and if they would go back now to get trialed, very little of them will pass because of their toxicity and their nephrotoxicity and other toxicities. Concerning cresomycin, I've read about it. I haven't used it. It seems to work in a very interesting way, especially attacking the ribosome. I hope that the resistance development to cresomycin is low, and that way we would be able to use it properly. And I hope the usage of cresomycin by infection control programs would be put in the right way, not use it straight on everywhere. Use it as a last resort to because it actually tackles multi-drug, extensively drug, and pan-drug resistant bugs.
Okay. Thanks, Doctor. I know we are like past the time by 5 minutes. We have one last question. I think it was just added. So we can, if you don't mind, we can address this question before we close. Yes. Okay. So the question says, thank you for the informative session and insightful discussion. Do we have a regional think tank to lead the AMR agenda as it's going high at priorities across the globe and probably for the region? Can we have a regional repository for AMR and antibiotics use across all countries where also we can have countries' profiles? Probably this can create positive cross-learning between countries.
Very nice question. That's I'm just gonna answer in one sentence, and I'm gonna give it to Dr. Kenj to address more. But this is my take on this because I've been going around the countries to do the trainings, and that would be the most beautiful case scenario you can ever think of if that would work, Rashad. The problem is a lot of countries don't like to share data, and a lot of countries want to do their own approach to things because they think they know better instead of using other models that work somewhere else. And this is where the bottleneck is. It's not whether we have the think tank. In our region and at AUB, we have the best of the best people. I'm not talking about myself. I'm talking about Dr. Kenj and the others. But the problem is they're either not given the chance to actually lead where it needs to be led, or there is really nobody, as we mentioned before, they're not sitting at the same table thinking collectively how to face the problem all together. Everybody's trying to have their own piece of the cake.
Yeah, I think not much to add, except this would be the dream. This is, you know, the triangle that I showed. I think this would be the dream, because if we don't put our efforts together, it's going to continue to be fragmented work that will not be as impactful as if we have a regional collaboration. But we're working towards establishing something at the regional level, and hopefully we'll see some output from that.
Okay, thank you so much. So on behalf of the Epidemic and Pandemic Preparedness Program at the Global Health Institute, I would like to thank you all, our distinguished speakers, our attendees. Thank you so much for the insightful presentations and the rich discussion at the very end. This brings us towards the end of our webinar. And just to let you know, this is the first of a webinar series that we will be hosting as part of the Epidemic and Pandemic Preparedness Program. So looking forward to having you all in our next webinars as well. Have a great day all.
Thank you.